All right. Good morning, everyone. Thank you for being here. My name is Callum. I'm the current programs and community outreach intern with the Epilepsy Foundation. So before we get started, I introduce our speakers. I just want to go ahead and thank our sponsors for today's symposium. So Charlotte's Web, Jazz Pharmaceuticals, Pharma, and SK Life Science for providing our gold level sponsorships for today. And I'll go ahead and present our speakers. So our first speaker is Dr. Jacob Pellinen. He is an assistant professor of neurology at the University of Colorado School of Medicine and an epileptologist for the University of Colorado and VA Regional Medical Centers. He went to medical school at the University of Colorado and trained in neurology and epilepsy at New York University. Since joining the adult epilepsy group at the University of Colorado, he's become chair of the professional advisory board for the Epilepsy Foundation of Colorado and Wyoming, and director of quality improvement, and the co-director of continuous EEG for the Division of Epilepsy at the University of Colorado Hospital. And he spearheaded his department's involvement in the epilepsy learning healthcare system. His research interests include finding ways to improve epilepsy diagnosis, reduce treatment gaps, and improve quality of life for those living with epilepsy. And our second speaker today is going to be Gaetha Mills. She is a certified neuroscience registered nurse who has worked in neurology at Swedish Hospital for 20 years. She is engaged with the Epilepsy Foundation. She serves on their professional advisory board as well as many other committees and activities, including volunteering as a camp nurse at their annual summer camps. And Gaetha is passionate about caring for people and living with epilepsy to help improve their lives. So I'll go ahead and turn the podium over to our speakers.
Thank you, Callum, and welcome to the Epilepsy Connect Symposium. I see some familiar faces here. And so this morning's talk, we wanted to give an overview of the epilepsy journey, which was kind of a challenging topic to think about because where does a journey start? Where does it end? It's different for everybody. And I think that there are some commonalities between journeys and experiences that people have that I wanted to touch on today. So part one of the epilepsy journey. What I'm going to talk about is mostly how seizures start, what different symptoms people have, what is seizure classification, what is the first encounter with the a healthcare professional supposed to look like, and that initial phase of the journey. Gaetha is going to talk more about specifically the epilepsy monitoring unit, which I think is a really important thing to understand because not everyone has a full picture of what the diagnostic testing looks like from the outset, and I think that that's an important thing to talk about. So like I said, everybody's journey is different. There are many different causes of epilepsy and seizures. There's many different ages of onset, different symptoms at onset, different treatments, and some things are the same between people and some things are different. And I'm going to highlight some of those today. And so if you have been in a doctor's office and talked about seizures, you may have talked with your doctor about this or your healthcare provider about what a seizure is. But to review, a seizure is a sudden burst of electrical activity in the brain. And generally, seizures are short-lasting, sudden onset. They last for about 1 to 2 minutes on average. It's the average duration of a seizure. Sometimes they last longer or shorter, depending on what type they are, what part of the brain they're coming from. And the symptoms between seizures can be quite variable between people. So depending on what part of the brain a seizure is coming from, you can have very different symptoms. So if you have a seizure that's focal in onset, meaning it's coming from one confined part of your brain, and it's starting in the part in the back of your brain, in your occipital cortex, you might have visual symptoms, or if it's starting in the part of the brain that controls movements, you might have shaking of a limb. And everybody's brain is capable of seizures. So one thing to point out is that all of our brains run on electricity, so everybody could have a seizure. And 1 in 10 people do have a seizure at some point during their life. And 1 in 26 will have recurrent seizures, which is what epilepsy epilepsy is. And the underlying cause of the seizures really explains the risk of recurrence. So how likely, if you've had one seizure, how likely is it that you'll have another, is really determined by what your risk factors are. And epilepsy is a large, essentially an umbrella category that describes what anyone who has a risk of having more than one unprovoked seizure. So this is a flow chart from epilepsy.com, which is also a great resource if you're not familiar with the website. There's tons of resources on that website for all sorts of questions you may have. But I thought this flow chart was a good description of what happens when you have an event and you're not sure what it was. So a lot of times it can be difficult to receive medical care initially, early on, because you're not sure what just happened to you, especially if the seizure has impaired your consciousness, or even if you've had another event that was relatively subtle and you're not sure what it was. It can take some time to actually decide to go to an emergency room or talk to your primary care doctor about that. But that's usually the first line of medical evaluation. Either something, a larger seizure happens, or somebody sees something that happens and you go to emergency room, or maybe something is a little bit more subtle and you talk to your primary care doctor about it. And at that point, whoever your healthcare provider is or whoever you're seeing should be taking a careful medical history, ordering some tests, and Gaetha is going to talk a little bit more about some of the testing later on, but you could get blood tests as well and brain imaging at that point. And the whole purpose of this is to figure out what this event was. Could it be epilepsy? Could this have been a seizure? Or is this potentially something else? And so it's important to realize that there are a lot of seizure mimics. Certainly, we want to do a complete evaluation and figure out what caused the symptoms you were having, but there's a lot of possible causes at this fork in the road. Could be something coming from your heart, could be a migraine variant, could be a sleep disorder, a movement disorder. And I've also seen people in my clinic who have things like intermittent low blood sugar, really low blood sugar due to tumors and other things. So it's very important at this initial fork in the road to take a really broad view of things and figure out what could be causing the symptoms. Yeah.
Percentage-wise, how often are you able to do that?
So I'll talk about this in a little bit more detail. If it is a seizure in epilepsy, you can find some underlying cause or etiology about half the time. Okay. And for all the people that come into my clinic, for instance, who have an event of unclear etiology, we're not sure what it was. Could it be a seizure, epilepsy? At least 30% will have something that's completely unrelated to epilepsy, and sometimes more, depending on year and season. So, so that's why, I mean, it's like really important to keep a broad picture of what could be going on and do it through a medical history, exam. Someone should do a neurologic exam on you if you're going to an office complaining about neurologic symptoms. So if they don't do that, think about maybe seeing someone who will. And then you should get imaging, some testing ordered at that time too, because that's really, even if we say, okay, this was definitely a seizure, we really need to decide what the risk of additional seizure. Should I start a medication now after your first event, or should I wait and see if this happens again, right? And some of that, should we wait or should we start a med now, comes down to what the results are on the testing. So what causes seizures? I have not been keeping track of time, but I think we're doing just fine. All right. So what causes seizures? Like I mentioned, there's a lot of different causes, and about half the time we don't know the cause yet. I say yet because there's a lot of research going on in this area. We're learning a lot about genetics. We're learning a lot about the different causes of seizures. And so as time goes on, I'm reevaluating people who have a diagnosis and trying to figure out, do we have any new clues as to what's going on? Do we need to do some repeat testing now? And causes tend to differ by age. So whereas when seizures start really early in life, in children, it might be more likely to be genetic. In young adults, it could be more likely to be related to an accident, head trauma, stuff like that. And later in life, it could be more likely to be related to things like strokes or tumors or vascular disease that's more subtle. And so there can be identifiable causes that determine how we go about treating seizures. So different causes might require different treatments. So that's also why it's important to try to figure out what's going on, because if something's related to an autoimmune condition, for instance, you might need immunotherapy. If it is related to a structural cause, you might need some sort of surgical approach to address that. That's all part of the workup when you're initially seen, is to figure out what the optimal course of treatment would be. And feel free to keep interrupting me if you have any questions. I'm happy to go on tangents and talk about other things as well. So one thing that I thought would be important to talk about this morning is seizure classification, because this is confusing for everybody, including doctors and healthcare providers, because it changes over time. So in the kind of more historically, you might have heard of terms like petit mal and grand mal seizures. Those are from the French and kind of more ancient in our seizure classification, but the way we describe seizures has been updated over time. And the most up-to-date version was published by the International League Against Epilepsy in 2017. And it tried to streamline and kind of simplify the language we use to describe seizures into two primary categories. Either they're focal, meaning they're rising from a confined region of the brain and then potentially spreading, or they're generalized, happening in the full brain all at once. And the generalized onset tends to be more related to genetic epilepsy syndromes and childhood type seizures. And focal onset tends to be a much larger category of seizures, and often happens with most people who develop seizures later in life in adulthood. They tend to be focal. And another important characteristic of seizure classification is whether or not they impair awareness. So that's important, because that generally seizures that have caused impaired awareness tend to be more dangerous. And so, and then of course, if we don't know the onset of the seizures yet, we're not sure if it's focal or generalized, there's a classification for that type as well. And in that group, we're more focused on just describing the symptoms that people have. Any questions about that? You may have heard other terms for classification, such as the terminology just before this classification was like partial onset seizures, or there's been every 10 years or so, there was an update that we are moving more and more to just using focal or generalized. And as I mentioned earlier, that initial diagnosis can really be a challenge for people. And it can be a challenge from the patient's perspective and from their doctor's perspective and the healthcare system as a whole, because especially if you have subtle symptoms at first, if your seizures are focal and maybe you only have a recurring sense of deja vu or very unusual smell and it's relatively subtle, it may take a while to realize, like, maybe this is maybe something's happening that I should see a healthcare professional about. And then from the healthcare provider's perspective, if the symptoms are relatively subtle, it can be a challenge to figure, well, is that a seizure, or is this something else? And at that point, we need to start connecting the dots and ordering some tests to figure out what's going on. And so it's definitely important to speak up about unusual symptoms that you're having, particularly symptoms that are recurrent. So, sometimes we all have, unusual symptoms. Oh, I had some dizziness the other day, or I felt really tired. I don't know why, but symptoms that happen that are always the same are particularly concerning when it comes to seizures. So if they're always the same and they're always short lasting, and so those are kind of the hallmarks of seizures: short lasting, sudden onset, similar, sometimes very unusual symptoms. And when you go for a medical exam, you should be making sure that the person who's evaluating you is also doing what they should do, which is performing a medical exam, ordering appropriate tests, taking a thorough history. And that's one thing that we find is often lacking in emergency departments and urgent care settings is, did they really ask you about your history leading up to that? Were they more concerned about just this event that brought you in, or did they actually want to know, had this happened before? Were there any smaller versions of this that happened before? Because that's the information that you need really to piece the story together. And then the common tests are EEGs and MRIs is what you order. And to arrive at a clinical diagnosis, this is also an important definition to be aware of. It's because it's relatively new. Historically, I think there was a sense that everybody was allowed to have one seizure. You go into an emergency room and they'd be like, oh, this was just one time. Well, come back if it happens again. And that's actually dangerous, in my opinion, because a lot of times they do happen again. And you want to make sure that if someone has a risk of this happening again, you start a medication so it doesn't, or that you reduce the chance that it does significantly. And so for a clinical diagnosis, you can have more than one. You have at least 2 unprovoked seizures more than a day apart, then that qualifies as a diagnosis of epilepsy. But if you just have one seizure, but you have something that we identify that's a risk of it happening again, that also meets epilepsy criteria. Because that just means that you need to be on a medication to stay safe. And that's ultimately the important part. What
you said other types of risks.
So this is why we do an MRI and an EEG. Sometimes if you're in an emergency room, they'll just do a CT scan and start with that. But if you see some sort of structural abnormality on the imaging that explains the seizure risk, or could be where the seizure started, or if on an EEG you see an abnormality in the brain waves that suggest part of the brain is at risk for seizures, either one of those things would bump up your risk more than 60% chance of that happening again. And sometimes just based on the clinical history too. So if you have a strong family history, everybody on that side has seizures or something like that. There's other characteristics outside of just testing that I would say are high risk. All right, necessary testing, and I'll talk about this really quick. So like I said, maybe in an emergency setting or urgent care, they'll get a CT scan, which is really a fast test, good for rapidly determining if there's any blood in your brain, a stroke, tumor, something big and bad that they need to deal with right away. That's why they like to use it in an emergency room. But the test that we really like for seizures and epilepsy is an MRI. And this is important because it really gives us a good picture of the structure of the brain and if anything could potentially be causing seizures. And in about 10% of cases after people have a first-time seizure, we can find underlying structural abnormality. So it's, 1 in 10, it's not super common, but it's super important. Okay. And then the EEG, so MRIs look at brain structure. EEGs, on the other hand, look at brain function. So we're looking at brain waves on an EEG. And in this test, we put electrodes on the scalp and monitor for the electrical rhythms of your brain. And it's safe and non-invasive. And we can see subtle signs of brain regions that might be involved in seizures using this test. And some of the terms you might hear are epileptiform discharges, spikes, spike in waves, focal slowing. These are some of the terms used to describe common abnormalities on EEGs. And not everybody has abnormalities on them. So a lot of times, the majority of people I see in epilepsy clinic have normal EEGs in between seizures, and they only become abnormal when they have a seizure on EEG. So similar to an MRI, you may not see abnormalities all the time, but it's really important to check, because if you do see an abnormality, that's very informative and actionable. All right, and then treatment options. I'm actually going to talk more about treatment options in a talk a little bit later this morning, so I'm not going to dwell on this too much. But the most important question is, do I or do I not start a treatment, to protect my brain against seizures? And about 2/3 of people with epilepsy will respond well to medications and successfully control their seizures with those, and about 1/3 will not. In those cases, we have other therapies available, and which again I will talk more about later. But there's dietary therapy, there's surgery and devices. Surgery involves potentially surgical resection of an area that's causing seizures, all the way down to neurostimulation and minimally invasive brain surgeries, which I'll again talk a little bit more about in detail later today. But those are kind of the spectrum of options for treatment. And so the treatment goals, and if you're seeing somebody who's taking care of you for seizures or epilepsy, this should be your personal goals, and it should be their goal as well. So no seizures and no side effects. And if you're not to that point, you should, and this may seem like a pipe dream to some people, but it's worth working on, because we do have over 30 anti-seizure medications on the market, multiple devices, and if you're not happy with the medication that you're on, or the dose of the medications or the efficacy of the medications, it's worth at least having a conversation about alternatives, what things are in the pipeline, what clinical trials are available, what else can we be doing to continue working towards that goal? Because you should always have a goal. You should all have goals in mind. So with that, I think we should save any questions for the end, but I'm going to turn this over to Gaetha to talk a little bit more about the epilepsy journey, and specifically the epilepsy monitoring unit.
Thank you, Dr. Pellinen. Good morning. How are you guys doing? Oh, good. Okay, well, you're all awake. That's good. Okay, so what is an EMU and how do you get there? Well, you drive. Dun-dun-dun. Okay. That's right. That's right. I knew that was a bad joke. Okay, so go ahead. Oh, bingo on Wednesday. Okay, thank you. So an EMU, or an epilepsy monitoring unit, is just part of a epilepsy center located within a hospital that are, dedicated beds that have certain hardware and hardwired things, and dedicated, educated nurses that are specific, have specific knowledge about epilepsy. And then an epilepsy center is it's a criteria that the NAEC, which is the National Association of Epilepsy Centers, gives out. So essentially there are a couple different categories or levels of centers. In town here in Denver, there are several different level 4 centers. Those are the kind of the highest operating levels, just meaning they have all the people that know all the things about epilepsy and all the different gadgets to do anything that would need to be done for epilepsy. So how do you get to an EMU? If you're seeing a neurologist or epileptologist and they determine that you need epilepsy monitoring, they're just going to send a referral to an EMU center, and that would come to someone like me. So a nurse or some kind of an epilepsy navigator, maybe a social worker, would receive that referral, and they're going to call you and set up the appointment. And the reason that we'd be going to an EMU, like Dr. Pellinen mentioned, so if you have, a routine EEG or an hour-long EEG, often if you have epilepsy, but you are not seizing, your brainwave activity may look normal. And so it's sort of like a false negative. So essentially, the EMU stay is going to be a stay where for an extended period of time, you're hooked up to an EEG and we're monitoring that electrical activity within your brain, right? Sorry, I digress. I'm really good at that. So when you set up the appointment with the epilepsy navigator, then probably he or she is going to send you some written information. I have like a 1-page form, and it's where are you going to go, what time are you going to get there, and a little bit about what to expect. And some of those things people are surprised by, such as you're probably not going to be allowed to get up out of bed on your own because you might have a seizure and fall down, and because there are all kinds of wires everywhere. Sometimes people come in, and if they haven't had those expectations, they're really unhappy. Like, what do you mean I can't leave the room and I can't go to the bathroom by myself, and I'm going to have this stuff on my head for 5 days? So so you should receive all that information beforehand so you know what you're getting into. A lot of people are concerned about insurance. Your insurance, if needed, will be prior authorized by this navigator person before you come in. So that's generally not something you need to worry about. If you do have questions, certainly ask them, and they should be pretty knowledgeable on that subject. Also, sometimes folks that work need some kind of documentation for their employer, and that's something that that navigator would be able to help you with. Okay, so what are we doing? We kind of talked about the fact that when you come into an EMU, you have 24/7 monitoring. So literally, guys like Dr. Pellinen sit in front of a computer and watch the squiggly lines of your brain go by. No, it's amazing how fast they can read this stuff. So, but you are being monitored at all times. We're watching your brainwave activity, and then also these rooms have audio and video monitoring, so that when you do have an event, we can see clinically what is your body doing and correlate that to what is your brain doing during that time. This is a picture of a very fancy EMU that is not at my hospital. It's at Rose Hospital, one of our sister locations. But it's just, you get the idea, it's generally, you know, a hospital room. I think most places at this point in town, you are going to have your own room and have the ability to have visitors and that kind of thing. You're there for a pretty long time, so we try to make it as comfortable as possible. Okay, so when you're there, we're usually having people come in for sort of 3 different reasons. And one is to classify your seizures, whether you're getting a diagnosis of epilepsy that you don't have, or you already have a diagnosis and we're trying to figure out more about exactly where your seizures are coming from because your medications aren't working. You're in that 1/3 of people, or else we're ruling out other diagnoses. I think Dr. Pellinen mentioned a couple of those things. So syncopal events, different things like that may look like seizures, and we're going to figure that out. Another reason you might come in is for medication management. So some people with epilepsy I kind of relate it to people who are like brittle diabetics. Everybody sort of heard that term. So some people are just very, very sensitive to any changes in their epilepsy medication. And so sometimes your doctor will feel like it's important to bring you in and have you in a safe place because you might tend to have, you know, a cluster of seizures or you know, more aggressive seizures than you normally do. So you would come into the EMU just for medication changes. And the other reason would be sort of surgical workup / what we call phase 2 monitoring. So in the EMU, we have 2 phases, phase 1 monitoring or scalp monitoring, where the electrodes are glued to your scalp, or phase 2 monitoring or intracranial monitoring, which is invasive, and it's either grids and strips or something called SEEG, which I think Dr. Pellinen may be talking about later, or somebody else is talking about, or I can talk to you afterwards if you have questions about that. So those would be kind of the main reasons that you're coming in and what you're having done. When you come in, there's a lot of things that we're going to orient you to just because the room is kind of busy. There's a lot going on. So you're going to get an event marker, which is just like a push button. If you yourself are aware before you're going to have a seizure or an event that's going to happen, you have an aura or you have a strange feeling, you can push that event marker. Or if you have family or friends or loved ones with you, they can certainly push that event marker if you have an event. And honestly, that mostly helps those reading physicians when they're scrolling through your brainwave activity at a very fast clip to slow down and look what's happening around this time. A call light, which is pretty standard in every hospital room at this point. You're going to have telemetry or a heart monitor placed. And so you're going to have some more wires, leads placed on your chest in a little box probably. So just sort of lots of wires in general. And for that reason, as I have already mentioned, most of the time places, centers are going to let you know that you can't be out of bed without assistance. And that might be staff of the hospital, or it might be, you know, friends or loved ones, but generally you're not going to be able to get up by yourself. Need for IV access. This is one of those things that I have in my form letter that I give to people beforehand. People are like, why do I need an IV? I don't, you know, there's nothing wrong with me. I don't need a bunch of fluids. So you just have an IV in case there's an event in which we need to give you medication that you can't take orally. So it's not necessarily a thing where you're going to be hooked up to a pole with fluids running all the time. We just have access to give you medication in the case of an emergency. So obviously we're letting you know that there's a camera in your room. We can hear every conversation you're having, not that we're sitting around listening to it, we're really not. But because of the fact that you do have video and audio, we would want you, for instance, to have on the proper clothing just for your, you know, protection, that kind of thing. Okay, so the plan for the week when you come into an epilepsy monitoring unit, and I do tell people the time can vary. We usually at my center, we tend to admit folks almost always on Mondays exclusively. Other centers have a more staggered approach, but I always tell people to plan for the work week. You may be there for 3 days, you may be there for 7 days, or even maybe 10 days, for instance, if you're having phase 2 monitoring, but kind of that week-long, a week is sort of the idea you should probably have in your head if you're going into this. You know, if you have seizures every single day, and in the first 2 days we capture 7 events, well, we probably don't need to keep you for a week. But oftentimes folks are there for around 5 days. So essentially we're collecting the amount of adequate data that we need. And then once we do that, we're going to give you your medications back or change your medication regimen. And then once the doctor and you feel like you're safe, then you get discharged. The other thing that often happens when you're in an EMU, if you're there and you have a diagnosis of epilepsy and are kind of going through next steps, is going to be some imaging. Might have an MRI, might have something called a SPECT scan. And actually, I had a bunch of slides in about imaging and then I took them out. So happy to answer questions about that if people have questions about anything like that later. So what can we do to ensure that while we are holding you hostage in the hospital for a week, we actually get that data that we want? Well, so obviously the plan is that we're going to reduce your medicines, right? And for some people, it might be that their medications are reduced by about 50%. Sometimes people's medicines are taken totally away. It's a conversation that you and your doctor will have when you're admitted to make a plan that feels good to you and that we feel like is safe, but also we get the data we need. So other things we can do are sleep deprive you. At Swedish, we try to let you sleep from 2 to 6, but we try to keep you awake all the rest of the time. Sometimes do people fall asleep and the nurse isn't right there? Like, yeah, and then we come in and poke you. It's 1:30, wake up. And that is just something that's going to irritate your brain a little bit, right? To try to keep you awake a lot. EEG techs can come in the room and do a few different tests. And there's something that they do called hyperventilation and photic stimulation. They're flashing bright lights at you and having you do different breathing patterns. And oftentimes that'll elicit a seizure. At Swedish, we have rowing machines and a bicycle. I think most places have a device or two like that that can be placed in your room to, one thing, let you move around, but also often if you're exercising to the point that you're kind of working up a sweat, that might cause a seizure. We talked about meds. Okay, so what happens if you do have a seizure? It's scary, right? Most of the time when people have seizures or have epilepsy, their whole kind of goal is no seizures. You don't want to have a seizure. So it's a little bit antithetical. You're coming into the hospital and we want you to seize. So the staff is going to take care of you. And how they're going to do that, firstly, in medicine, we talk a lot about the ABCs, airway, breathing, circulation. Without those, life is kind of a no-go, right? So if you are having a seizure and having any trouble with airway, breathing, or circulation, we would be placing oxygen on you. That'd be the first thing that would happen. And suctioning, a lot of times people will have a lot of secretions if they're having like a generalized seizure, tonic-clonic seizure. So we're taking care of that. At most places, we're going to remove the covers from your bed. And I think sometimes people think that's really weird. And the reason that we're doing that is we want to see what every part of your body is doing. Are your toes twitching or are they still? What's happening there? So the staff would probably push that event monitor, so you don't need to worry about that being something that doesn't happen. We're going to check your vital signs. We're going to talk a lot out loud to the camera, which when nurses or hospital staff are new, they think is really weird and uncomfortable. And you guys definitely think it's weird and uncomfortable. But the reason for that is just so that when your epileptologist is reviewing, they know what's going on. A lot of times when folks, especially if you have like kind of a big seizure, a generalized seizure, 6 nurses will be in the room and it's a little bit chaotic. So it's scary for patients. And then when a doctor is trying to watch and listen and learn and see everything that happened, it can get a little bit tricky. We don't have like the greatest audio and video technology in hospitals. So that's another reason I think I have music or TV if possible, at least at my center. You're watching these videos and there's 6 nurses in there and somebody's seizing and making noises. And then there's like some rapper rapping. It's not all that helpful. So anyway, that might be something that you'll see that we do. All these things, I think in addition to having a seizure can be really disorienting and scary to a person, especially if you do lose that awareness. And then you kind of come to, and there's like all these people in your face and your covers are off and a lot of just seemingly weird stuff going on. So certainly one important thing that we do is trying to reassure the patient, you're in a safe place, everything's okay, we're taking good care of you, that kind of thing. If you are out of bed when you have a seizure, obviously we're not going to try to put you back in bed, we're going to try to keep your head safe, and that's about it. The other kind of big thing that staff does when someone is in the EMU for monitoring is what we call tasking. So once the environment is kind of safe, then the nursing staff is going to do some tasking. And I think I actually missed something on the last slide. One thing we love to do when we walk in a person's room and they're having a seizure is say, I'm going to give you this phrase and I want you to remember it, pink Cadillac, pink Cadillac. And then hopefully we remember 5 minutes later to ask you, what was that phrase? So anyway, tasking is asking orientation questions. What is this called? Can you raise your arms? Can you wiggle your toes? Give me a thumbs up. Repeat, today is a sunny day, that kind of a thing. And probably your staff is then going to be talking loudly into the camera to say, this patient did or didn't do this, or they're following commands, they're not following commands, all that kind of stuff. Because again, especially with the video quality that a lot of us have in our EMUs, it's hard for the doctors to actually tell how you're responsive or not. So that is all the really disorienting stuff that we do to you. The reason that we're doing that is sometimes knowing what part of your brain is working and when it's working during or after a seizure can be really helpful to the doctor to figure out this puzzle of what's going on with you and what can we maybe do to fix it. Make sense? Okay. So that's kind of the story of the EMU and what it sort of looks like. When you are going to leave the EMU, you're going to receive written instructions. It's going to include your medications. Sometimes you're going home on the exact same medications and same doses that you came in on. We're still going to give it to you in written form. A lot of times those get tweaked, even if it's just a very small dosage change of the medicines you're currently on. So you're going to receive that in writing, and then you're going to be given a follow-up appointment. In some centers, they will schedule that appointment for you while you're there, which I think is really nice. Other places you may have to call when you get home. But generally speaking, they're going to want you to follow up with the doctor that sent you in, or your referring doctor, within 2 to 4 weeks. If you are sort of going down this surgical path, you most likely are going to also be asked to see the epileptologist who watched you throughout the week during your hospital stay, right? If you are a surgical candidate, you're also going to talk to that navigator person again. In fact, she or he's probably going to become your BFF, because they'll talk with you to do all the scheduling of the myriad kind of testing and that kind of thing that you might have done. So the last thing that I just wanted to kind of say, I think especially if person is going into the epilepsy monitoring unit and getting kind of for the first time getting that diagnosis, you need to get involved. Getting involved will be helpful to your mental health for sure. And obviously you guys are here today, so you know about the Epilepsy Foundation. Somehow you're hooked in a little bit. The foundation has just tons and tons of resources and puts on lots of great educational events and then fun events where you can meet other people with epilepsy, that kind of thing. So I would highly encourage you to reach out to the foundation. There are, at this point in our sort of post-COVID world, several online support groups for adults and children, and then, you know, variations of those kind of things. So, and the Epilepsy Foundation can help you get hooked into those for sure. I would recommend that. And then possibly considering talking to a therapist or counselor, again, especially if this is all new to you and you've just been hit with some pretty big news about your health. So does anybody have questions about anything I've said or didn't say, didn't cover? Okay. Lastly, I just wanted to have my information if you want to copy it down. I have been a neuro nurse in this Denver metro area for 20 years. So I kind of like know everybody and all the things. I'm not that I'm so smart, but just that I have like institutional knowledge. I'm more than happy to have an email with you or phone call with you if you have questions about the provider 10 miles down the street from me, or, you know, I've had this thing happen and I wonder about the next thing. I get really weird and off the wall questions. So happy to help in any way I can if I can help you guys. And then thank you to our sponsors, and thanks again for your attention, and thank you to the Epilepsy Foundation.